This is Stephanie Huff, and I'm recording another concept on sensory perception. This one is going to be on hearing impairment. Just an overview. About hearing impairment. Children, there's about 1 million have some degree of hearing impairment. Adults, there's about 36 million that have some type of hearing loss as well. When you're looking at hearing impairment, it is expressed in terms of decibels, which are units of loudness and rated according to severity. Children with only mild hearing loss, and that's 30 to 45 decibels, miss about half of everyday conversations. Hearing loss greater than 90 decibels is considered legally deaf. Hearing impairment does impair their ability to communicate. The deficits may be partial or total, congenital or acquired, and it can affect one or both ears. Looking at the severity of hearing loss, slight to mild hearing loss is 26 to 40 decibels. Some speech sounds are difficult to perceive at this state. And moderate hearing loss is 41 to 60 decibels. Most normal conversational speech sounds are missed. Severe is 61 to 80 decibels. Speech sounds are not heard at normal levels, and that's just normal communication levels. Profound is 81 to 90 decibels. No speech sounds are heard. And deaf is greater than 90 decibels, and no sounds at all are heard. And so I've put this graph here at the bottom that just kind of shows you the different sounds and how many decibels are used, and some of those sounds can be cause hearing loss if it's a long-term. Etiology, conductive hearing loss, anything that causes a disruption in transmission from sound from external auditory meatus to the inner ear is considered this type of hearing loss. Most common cause is from obstruction, like from impacted cerumen, edema of the canal, stenosis, and neoplasms. Other causes of conductive hearing loss could be perforated tympanic membrane, fluid, scarring, and tumors of the middle ear. Sensory neurohearing loss. These are disorders that affect the inner ear, auditory nerves, and auditory pathways of the brains. Noise exposure, loud impulses like explosions or loud continuous noises such as machinery can cause sensory neurohearing loss. Sound waves effectively transmitted to the inner ear, but they are lost or damaged, have these lost or damaged receptor cells. They can have changes in the cochlear apparatus or auditory nerve abnormalities, decreased or distorted ability to receive and interpret stimuli. Your high-frequency sounds are mostly affected by sensory neurohearing loss, and there is a significant cause of sensory hearing loss is damage to the hair cells of the organ of Corti. And that's basically what happens in your sensory neural hearing losses, is those damage to those hair cells on that organ of Corti. Other causes could be ototoxic drugs. They also damage those hair cells. Some of your tumors could be acoustic neuromas. Vascular disorders, degenerative diseases, infections such as bacterial meningitis, trauma, demyelinating diseases, maternal exposure to rubella, viruses, meningitis, trauma, Meniere's disease, and aging can also are also causes of sensory neural hearing loss. All right, looking at presbycuspis. Hair cells of the cochlea degenerate with aging. Hearing begins to decrease in early adulthood and will progress as long as they live. Higher pitched tones and conversational speech is lost initially. This is the anatomy of the ear. And so you can see you've got the external ear, which does include the pinna, the ear canal, and the tympanic membrane. Your middle ear is what is included in the three bones, the malleus, incus, and stapes. And then you have your inner ear, which includes your semicircular canals, the oval window, nerves, cochlea, eustachian tube, and the labyrinth. Risk factors. 50% of hearing loss in children is genetic. 25% is environmental around the time of birth, and the remainder is from unknown causes. They have a positive titer for torch infections, and that is toxoplasmosis, rubella, cytomegalovirus, syphilis, and herpes. Also, craniofacial abnormalities are risk factors for hearing impairment. Other risk factors are very low birth rate, less than 1,500 grams, bilirubin of greater than 16 milligrams per deciliter, aminoglycoside medication administration for more than 5 days, a low APGAR score at 1 or 5 minutes, bacterial meningitis, mechanical ventilation for over 5 days, and then some of your syndromes associated with hearing loss are going to be Down syndrome, Pierre-Robin syndrome, and Arnold-Chiari malformation, which is just a malformation in the brain. Prevention. Both loudness of the noise and the length of exposure contribute to hearing damage. And remember that noise level is measured in decibels. And so the louder the noise, the higher the decibel. So permanent damage can occur at volumes louder than 85 decibels. So hearing impairment associated with the use of earbuds and headphones can affect individuals of any age group. And that's just because they're listening to their music too loud. And this is known as a noise-induced hearing loss. It is associated with prolonged exposure to sounds of greater than or equal to 85 decibels over an extended period of time. This includes listening to loud music. It can also be caused by a single exposure to an intense impulse sound that's over 120 decibels or more like an explosive blast. You want to prevent this by avoiding situations that pose a risk and wearing ear protection in environments that involve exposure to known risk. Warning signs that may suggest auditory damage include the inability to hear another's individual voice from a distance of 3 feet away. Some of your other warning signs are going to be ringing in the ears, which is your tinnitus, and ear pain. Looking at the clinical manifestations in conductive hearing loss, loss of hearing at all sound frequencies occurs. Speech discrimination is good. They will benefit from an amplification or hearing aid. In your sensory neurohearing loss, they have loss of high frequency tones. This loss makes speech discrimination difficult, especially in noisy environments. Hearing aids are not beneficial because they amplify both speech and background noise. In presbycuspis, hearing loss is gradual, so patient and family may not realize the extent of the deficit. May be described as unsociable or paranoid. Family may think or worry that they are increasingly forgetful, absent-minded, or senile. Hearing aids and other amplification devices are useful in this type of hearing impairment. Tinnitus is the perception of sound or noise without stimuli from the environment. Sound may be steady, intermittent, or pulsative. It is usually described as a buzzing, roaring, or ringing sound. It is usually associated with a hearing loss. You want to identify early the signs of tinnitus for successful treatment. Infants need to be diagnosed quickly to ensure optimal development. Often an early symptom of noise-induced hearing loss or drug-related ototoxicity, especially with your salicylates, quinine, or quinidine toxicity. Other causes could be obstruction of the auditory meatus, presbicuspis, middle or inner ear inflammation and infections, otosclerosis, and Meniere's disease. And so you want to treat the underlying cause. In collaboration, you want to discuss or diagnose with the correct type of hearing loss, and nurses should help with education and explanation about the types of tests that may be performed and educating them about the alterations if they are found in performing these tests. All right, diagnostic test. You want to diagnose the correct type of hearing loss. A lot of times they'll use whisper test. They may do an otoscope examination. Your tempogram, which is the picture on the right, they actually insert this probe next to the tympanic membrane, and you get a printout of the results of their hearing, and it's all based on the vibration of the tympanic membrane. Tuning forks are also used to decide what type of hearing loss they have, and that is your Weber and Rhine test. Surgery. There are several different types of surgery that can be done. Your reconstructive surgeries of the middle ear, a stapedectomy is removal and replacement of the stapes, which is one of those three bones. And that is to treat hearing loss from otosclerosis. The structures of the middle ear can also be reconstructed by tympanoplasty, and that is to improve the conductive hearing loss. Chronic otitis media with necrosis and scarring are common indicators for a tympoplasty. Also, a myringotomy is when they place a small hole in the tympanic membrane and a tympoplasty tubes are placed. This is common in young kids with repeated otitis media. It can also be done in adults that have chronic middle ear fluid or effusions, and to keep that fluid draining. A cochlear implant is another type of surgery. It is for sensory neural hearing loss. It may be the only hope of restoring sound perception. It consists of a microphone, a speech processor, and a speech transmitter, a receiver and stimulator, and electrodes. The cochlear implant will function similar to the way the normal ear processes sounds. So the microphone picks up sounds, sending them to the speech processor, and they convert them to electrical impulses and sends them to the electrodes for transmission to the brain. It does provide sound perception, but not normal hearing. So they can recognize warning sounds like automobiles, sirens, telephones, doors opening and closing, and they may be able to learn how to interpret the perceived sounds, such as words, over time. And then there's always different ones that are uncorrectable hearing losses. All right, so your pharmacologic therapy is most often caused by upper respiratory infections or seasonal allergies. These can be treated with decongestants, and they might be helpful. Sudden sensory neural hearing loss, initially it is treated with steroids. For otitis media, antibiotics are going to be prescribed. There is no medications for permanent hearing loss. Amplification or hearing aid use does not prevent, minimize, or treat the loss. It just basically makes the sounds better so they can be heard. So hearing aids are individually prescribed by an audiologist. Proper design, fit, and regular maintenance is necessary to maintain effectiveness of the hearing aid. So there's different types of hearing aids. They are going to include a microphone, amplifier, speaker, earpiece, and volume. A lot of times they have an on-off switch as well. But there are different types of hearing aids. A canal hearing aid can be in the canal or completely in the canal. Then you've got the in-ear style and behind-ear hearing aid. And a lot of it's just going to be depending on what is better for the patient. It is important that these hearing aids be kept clean. When you're looking at amplification, this is an assistive listening device that can be used with hearing aids as well. They have white noise masking devices for clients with tinnitus, allowing them to block out the abnormal sound. And then you have your TTD and TTY telephones with amplifiers are available. Internet accessibility is useful in corresponding by email and helping to make restaurant and airplane reservations if they have difficulty using the phone and hearing of the phone. Additional therapies are going to be lip reading, signing, cueing, and finger spelling. Looking at the nursing process, you want to consider the following: the type and extent of their hearing loss, their client's adaptation to the loss, availability of assistive hearing devices, and the client's ability and their willingness to use these assistive devices, because a lot of times they won't use them. And the assessment, you want to get a good health history, their perceived ability to hear, the effects of the hearing loss on their lifestyle and function, risk factors such as ototoxic meds, upper respiratory infections or frequent ear infections, noise exposure, vertigo, and tinnitus, physical examination, looking at the apparent perception of normal speech, inspection of the external ear and the tympanic membrane. There's also tests of hearing, like the whisper test and the use of the tuning forks, assessing their cranial nerves, and also assessing their balance. These are your NANDA diagnosis for hearing impairment. All right, in planning, goals may include that the client will remain free from injury, wear hearing protection, and have no further loss of hearing, find the best method of communication with others, whether that be through sign language, hearing aids, writing, or lip reading, remain involved in his community and not experience social isolation or decreased feelings of self-worth. Promoting optimal wellness, you want to encourage the client to talk about hearing loss and their effects on the activities of daily living. Providing information about the type of hearing loss, refer to an audiologist as needed. Replace the battery in hearing aids regularly. They usually last about a week. If hearing aid has a toggle switch, make sure that it is in the appropriate position. You want to also talk with the family members about communication techniques that can be used to help them communicate effectively. You want to keep the hearing aids clean from cerumen and check them for patency. Facilitating communication. You want to wave your hand, tap them on the shoulder before speaking so they know that you're speaking to them. If they wear corrective lenses, ensure that the corrective lenses are clean and the client wears them. When speaking, you want to face the client and keep your hands away from their face so that if they do lip read, they can have full access to your lips. Facilitate communication. Continued, you want to keep the face in full light, reduce noise in the environment before speaking, use low-pitched voice, with normal loudness, because remember, most of the time it's the high-pitched voice that is, those high-pitched sounds that are lost first. You want to use short sentences and pause at the end of sentences. Speak at a normal rate. Do not over-articulate. Use facial expressions and gestures. Provide a magic slate for written communication. Make sure that their hearing aid is properly placed, turned on, and has fresh batteries. Other things is do not place the IV catheters in their dominant hand because they may need to use that hand to write. Rephrase sentences if they're having difficulty understanding. Repeat important information to make sure that they understand. And inform staff about the client's hearing deficit and the effective strategies for communication. You want to encourage socialization. You want to identify the extent and cause of isolation. They may not be aware that they are isolated. You want to encourage the client to interact with friends and family on a one-to-one basis in a quiet setting. They usually do much better with small groups. Treat the client with dignity and remind friends and family that hearing loss does not indicate cognitive loss, that they're not stupid or demented. Obtain a pocket talker. Often that will kind of help as well. You also want to involve the clients in activities that don't require hearing, such as like chess or checkers, and then refer to an audiologist for evaluation because they can help with amplifiers and hearing aids. Evaluation. Some of your expected outcomes can include that the client demonstrate successful establishment of method of communication. The client manifests growth and development milestones to maximum potential, and the family demonstrates positive methods of coping. So this is the end of hearing impairment, and if you have any questions, please let me know and I will try to help clarify.